Today is a practice run for a presentation I'm giving in Melbourne in a couple of weeks at a palliative care meeting on chronic disease and palliative care. And at the time I put the abstract in, it seemed like a good idea. And then as it came to fruition, I started thinking about it. I thought, what have I got myself in for? And it came about because I did 2 home visits for research patients with dyspnea, both of them with severe COPD, both of them socially isolated, both of them struggling, and one had been accepted onto our books and one had not. And I wanted to know why. And why was that fair or unfair? Why is it that almost every cancer patient gets onto our books at one point in another, but COPD doesn't, cardiac failure doesn't, end-stage renal disease? So is there something that we can do to identify this person really needs our help, but this person not just yet, let's wait and see? And so it's with that sort of undertaking is why I put it in, to see, can we do better? Why? The other thing is not just for symptom management, but for looking after the caregivers as well. So really that's where this all stemmed from, because we know that we're all unfortunately getting older. We know that there is a tsunami of frail elderly people coming our way, and we can't look after them all. The government can't fund all of it, but I would argue that we can do it better and cheaper and actually keep people out of hospital, so long term we can save the government money and provide better care. This actually was one of our patients several years ago. It was actually one of KG's patients that she took on. Severe COPD. He was in and out of hospital all the time. He's only young. He's isolated, he lives alone, and he had dreadful exercise capacity, dreadful anxiety, and he was taken onto our books. And you can see there that after regular visits, the number of admissions into hospital reduced dramatically. So that's the only end point, but if we'd done quality of life, hopefully we'd improve that as well. But he was someone with COPD that did go onto our books and was looked after by us. The difficulty with all of the chronic diseases is that they get sick, get a little bit better, get sick, get a little bit better, but they never often regain that function. So it's really difficult to predict who will and who won't progress. And then there's lots of arguments. What is end-stage disease? A few years ago I did a straw poll for COPD, and none of the respiratory physicians could really identify something that they used regularly to say this is end-stage COPD. And then the models of care. We're particularly different with hospice, acute care, home care, but other services work differently. So how would they manage? How do the rural regions manage, especially now that they're being decimated by SA Country Health and slashed their home nursing services? The GPs can't cope with it all, so we've got to think, how do we deal with this and what can we be smarter at it? This is one of my patients who now has passed away, but she epitomises what I'm talking about. She's older, she's living alone, she's got respiratory failure, she's got sleep apnea and uses CPAP quite effectively, heart disease and heart failure, bones are falling apart underneath her, and she's got a restrictive disease as well with her severe kyphosis. On top of that, she's got some renal failure. And then with the edema in her legs, she's getting leg ulcers and infections, etc. She's on a bucket load of medications, all of which interact with each other, and then she goes and falls. And those are some of the markers of what happens to these people. I took this out of the Australian Financial Review, and it's a really nice little cartoon, but this is how we used to live many years ago. We lived for a short time, we thought 40, 45 was old, then we'd get an infection, and then we'd die very quickly. And then along came, we've got clean water, we've got some medicines, and we've actually, this is more looking a little bit like the chronic disease type model. And now with medical advances, you can see it's a long, slow fade to death. And so this cartoon I've stolen from the Australian Financial Review of late last year. The way we die has changed as well. Years ago, we were born, or conceived, we were born and we died all in the same room and all in the same house. But now it's all compartmentalised into separate and different locations, and it's hidden away. The mode of death you've seen has changed. And then we've lost our community, and our network facilitators are really acutely aware of the lack of community support. Some of the church groups support and rally around, some of the service organisations, but as neighbours, we all live in our isolated little pockets, and we don't see our neighbours very often these days. So our community supports, the way we die has changed quite significantly. And often people will die alone, with no one around them. This was a survey that was published last year, and I've stolen the list from the quarterly essay which was published earlier this year on caring for our elderly. But it was a survey of what a good death might be. What do you want? And you can see the lists there. I do want to know when this is coming. I do want to have some control. I do want some dignity and some privacy. And I think we can all feel and equate with all of these things, that this is what people in the community think that a good death or dying well might be. And the model of care is changing from the early days. This is the haematological model really, although it should be up here somewhere with a day or two of palliative care involvement. But the model is changing, that we're getting to see people earlier. And so that means we need more staff to look after people. And it struck me when someone pointed out to me, I think it was Olnia pointed out to me, there are more respiratory nurses counting nebulizers and oxygen concentrators in the southern area network than community palliative care nurses. And I thought that's the wrong way around. So our nursing staff, our community staff are really understaffed and underfunded. And if we're expected to go from an early time, we need more resources. We know that early palliative care involvement improves quality of life in patients and length of life. This was published in America about 4 years ago, and it was really considered a landmark study at the time. The Americans thought they were onto something really clever, because we've been doing it for years. That is, taking patients with lung cancer, seeing them early from the oncologists, and providing support and care. But to them, this was a novel idea, because in America, hospice is the last 6 months of life, and you have to sign off from active treatment, and it's a completely different setting. So they changed what they did and really adopted a model that we know well here and use. But what it did show was there was better quality of life, less depression, and that they survived longer when they were involved with palliative care. So they randomised the patients, half to the usual oncology group, half to early palliative care, as you and I know how we work. And they thought it really was a landmark study which gets trotted out all the time. So that's in cancer. And this just shows the reduction in depression scores, anxiety scores, and general health scores. The improvement in scores, the reduction in symptoms. And you can see on the Kaplan-Meier curve that the red line, early palliative care, they're surviving longer with a better quality of life. What about in chronic disease? Again, published 2007 in Journal of American Geriatric Society. They took a couple of groups of people, but it had cancer patients and COPD and CCF patients. They were randomised to their usual care with their physician or to early palliative care involvement. They had just over 310 patients, and they were community patients living at home. Oldish, and their palliative performance score was 58, which is an average because it should be 50s or 60s, but I'll talk about that later. So moderate disability. And what this showed was that there was an improved satisfaction in the patients who were enrolled in early palliative care. So this is the satisfaction scores, and they were consistently higher at baseline after initial review and 30, 60, 90 days compared to usual care. But importantly, and this is what the governments are after, much, much cheaper. It kept people out of hospital. It stopped them fronting up to the emergency department. It stopped them going into ICU and being intubated and ventilated or having dialysis. So the costs were dramatic, and this is per day. So one hospital admission cost is thousands of dollars. One day in intensive care is over $1,000 a day. So it's expensive to put these people in hospital. So this was in patients with cancer or chronic disease. Their quality of life improved, and it was much, much cheaper. What about the caregivers? And this was a study published 2005 by David Currow and Amy Abernethy when she was working here. And what it looked at was the caregivers and their unmet needs, identifying that they are under considerable distress. And what it showed was that when specialist palliative care was involved, the number of unmet needs reduced, but importantly, their ability to move on after the death of their loved one was much, much better. So this is years at the bottom, 1 through to 5, specialist palliative care involvement, and no palliative care involvement. So if you were enrolled in the palliative care service, yourself and your partner who had died, you were able to move on with life much, much earlier than if you had not been. You ultimately ended up around about the same at 5 years. About 15% still were struggling with bereavement and grief issues, but the majority of patients relatives have moved on much quicker if you were enrolled in palliative care service. Imagine how much money that potentially could save from a government perspective. People back to work, people productively employed or engaged in their community again. Much better quality of life. This paper came from the Respecting Patient Choices program, which runs out of Melbourne. Some of the hospitals or units in Adelaide have picked it up. Essentially, it's advanced care planning. It's talking to patients and relatives. What's important to you? What are your goals? How do we look after you? What would you like to be looked after in those last days or weeks? Karen Dietrich, who's a respiratory physician, is now a clinical ethicist, but she was the lead author in this paper. Half the patients were randomised to the Grotty Medical Ward usual care, and we've all been up in 6C at Flinders. Half were randomised to Respecting Patient Choices. That had a social worker or a nurse who was trained in talking to patients and families about end-of-life care, goals of care, what's important to you. And what's really important that I want to highlight is these numbers here, the impacts of event scale. So this was looking at the bereaved relatives after their loved one had died. If you had had that conversation or series of conversations with the social worker or the nurse, as a bereaved relative, your incidence of post-traumatic stress disorder, depression or anxiety was significantly reduced if you'd had just that brief intervention. A brilliant piece of work. This is a PTSD score. You can see 5 versus 15, and none of them in the intervention group scored above 30, which was their cut point. And in the hospital anxiety depression scale, where 8 or above is significant and a marker of illness, none of them in the intervention scored above 8 compared to this group here. So again, really good evidence that just planning and talking to patients and relatives may be enough to reduce post-traumatic stress and bereavement, anxiety and depression. A vital piece of what we almost take for granted working with patients and families in palliative care. So how do we measure this? we are absolutely bombarded with scores and scales and charts, prognostic models, and so it almost is like being in a lolly shop. There's too much to choose from. It really does get confusing. And this is a score, believe it or not. That's the Peacock score. And we can talk about Peacock. Does it help us? Does it hinder us? How do we interpret it? So scales have been around for a while, or scores, and the first one was the Karnofsky one back in 1948, and that was developed for the very first chemotherapy trial, which was nitrogen mustard. And since then, and I might get Zach to play around with this in between now and 2 weeks' time, you could put so many different scores along there that have been developed over time. And this is just a little smattering of them, and I'm going to talk a bit more about the palliative performance score. AKPS we'll talk a little bit about because we're using that. I discovered the other day the PC Needs Assessment Tool, or palliative care, the PC NAT, which sort of seems to have died a natural death. I don't know that many people are using it around. The Prognostic Indicators Group, which comes out of the Gold Standards Framework from United Kingdom. Touch briefly on Peacock. The ALS score we'll talk about because we're using that in the motor neurone disease clinic, and I'll touch on the Bodhi score. This is just one table out of a report to the Department of Health in Victoria, for palliative care in Victoria, trying to summarise all of the scales. There's so many different scales, so many different domains that you could choose from. How do we choose one as a unit or a service to cover everything? It almost is impossible. How would you rate this poor old man left in the corridor in the emergency department, eyeballing with a palliative performance score or an ECOG? It gets confusing. So, the palliative performance scale is very similar to the AKPS. It's a functional assessment tool. 100 is where we should all be at, and 0 down to death. And it has 5 main elements of mobility, activity and evidence of disease, their nutritional and fluid intake, self-care and conscious level. And Peter Jenkins is just starting to roll it out at Resthaven to see if they can use it as a tool for their nursing homes, particularly given that they have so many care assistants who need to be able to communicate to each other. And this is the palliative performance scale. And you can see the 5 activities. You start on the left-hand side, which gives you the most power and the most weighting, then you work your way across. You know, sort of, well, a bit of reduced. If we think about Thelma, she was reduced activity. She really couldn't do anything, really. She was becoming so unwell. She was needing assistance with self-care, really needed showering. Her intake had started to fall off, and at times she got a bit confused. So she somewhere was sitting around a 50 or 60, and when you push the numbers side by side, they're reasonably similar to AKPS. But I like the boxes in here that you can work your way down and across, and it seems simple and intuitive. So it may be used to trigger extra planning and extra care for a patient, to say, well, they're dropping. Gee whiz, when we admitted them to Resthaven, they came in at a 70, but there's a big change here. And intuitively we know that, but if you're not seeing the patient every day and you're the one registered nurse and you're relying on carers, you can look and see that there is a change. So that's how it might be used, and to identify to the GP looking after those patients, there is a change here. We need to up the ante with care. The Prognostic Indicators Group comes out of the Gold Standards Framework, and there was a big push at conferences a few years ago, but it comes with 3 parts to it. The first part is the surprise question, which we use in a number of our research studies to estimate prognosis. Would you be surprised if this person was to die in the next week or month or 6 months? But this letter to the editor of Palliative Medicine came out of Meryn Gott's group, and she presented at the PCA meeting a few months ago. they're concerned that the question by itself just narrows it down too much, and may we miss things, and should we just be, it could just get used as a screening tool or a surrogate for screening, and how does it cope with COPD, with flare-ups and recoveries in such an unpredictable illness trajectory. But this is taken straight from their website, the GSF website. And this is the trajectories that we've seen previously and people put up all the time, but with typical case histories. So cancer, liver secondaries, breathless, fatigue, and we sort of see that she'll run along and have a quick demise. But the 84-year-old man with heart failure and more short of breath, in and out of hospital, decreasing recovery, so he just never gets back to where he used to be. And then this could be Thelma, really: COPD, heart failure, OA, dementia, following a fall, less active, eats less. So you can see how you could fit that little history into the palliative performance score each time going across. So you could combine a palliative performance score and the PIG. So the three aspects of it are the surprise question, some general indicators of decline, which I'll show you in a minute, and then some specific indicators in specific conditions. So again, taken straight from their website, the surprise question, but the general indicators: activity levels, which again falls into the PPS, comorbidities, general physical decline, advancing disease, difficult to manage, it's just not responding to treatments anymore, irreversible heart failure, weight loss, which is a significant sign, sentinel events, falls, and then falling albumin. This is actually like a Centrelink equivalent, but would be a disability pension. Is that correct, Janelle? Yep. So, but in COPD, what specific indicators might we look at? FEV1, less than 30%. Recurrent hospital admissions, it's well recognised that recurrent admissions, they do work poorly. On domiciliary oxygen, the Modified Research Council dyspnea score of severity, so shortness of breath after walking 100 yards, which is not a lot. These people get breathless just getting from their bedroom to their bathroom. It is a major effort and undertaking for them. Long-term COPD often ends up in right heart failure because the right heart just gets very tired, and get fluid retention, very difficult to treat. People who have been on non-invasive ventilation or intensive care, and the people who are on long-term steroids are some of the prognostic markers which say this person has a high risk of dying in the next 6 to 12 months. This is the Bodie score, published by Bart Shelley about 4 or 5 years ago. And what he did was took 4 items: the body mass index, a BMI of less than 21, the degree of FEV1 or airflow obstruction, the degree of dyspnea using the MRC score, and then the 6-minute walk, the exercise capacity. It's a score out of 10. Even if you score the worst Bodie score out of 10, at 12 months on the Kaplan-Meier curve, you can see that hardly any of them will die. And it was a well-validated tool. So that's the other difficulty we have. If we took one patient with COPD onto our books every week, at the end of 1 year, only 4 or 5 of them will have died. And in the hard reality of income outgoings, with our cancer patients, our incoming admissions usually equals our discharges or deaths, so our numbers stay static. But if we take a COPD patient a week, a CCF patient a week, we will be swamped. So how do we do it? I put this up just to show you, this is what severe emphysema looks like. So this is a CT scan. Sternum, vertebral bodies, right lung, left lung. This is the heart. So this is sort of normalish lung parenchyma through here. And you can see the centrolobular emphysema around the peripheries. And this is a massive cystic bullous on the opposite lung. Little strands of lung tissue in there, but essentially no normal lung function, no tissue for gas exchange. They're overinflated, their diaphragms are pushed down, they struggle. And these can pop and cause pneumothoraces, and they don't heal very well. So someone like this could score one of the worst scores on the Bodhi score, but still have a good chance of being alive at 12 months. Motor neuron disease, we're getting lots of experience. All of you have a lot of experience with that. But what markers may we use for rapid decline and deterioration? You sort of, again, intuitively can see people fading away, the weight loss, the speech changes, the slowness. The cognitive difficulties is tricky because of the frontotemporal dementia. The vital capacity falling below 70% as lung function, indicating getting close to needing ventilatory support. And frailty, and that's not me or my hopes for when I'm older up there, but gee whiz, I wouldn't mind hopefully when I'm 80 or 90 being that fit, compared to this poor old man in the bottom corner. Frailty is that concept of weight loss, slowness, ability to get up and go test. So you put someone in a chair, you ask them to stand up, walk across the room, turn around and sit down. How long does it take them? How many efforts do they have to get up out of the chair? The slower and the longer it takes, the worse they get. But again, using the functional assessment staging tool, which comes out of Canada, even if you've got the worst scores, you can see at 12 months still 70% of frail elderly people will be alive. But these frail people they can come with comorbidity illnesses, but many of them may just be frail. They don't have underlying COPD, they don't have heart failure, they're just getting old. This study came out of Scotland, published 2010, but really what they're showing is the older you are, the greater the chance you've got of dying if you've been in an acute care hospital. And the older people, the males, 85 and above, over half of them will have died at the end of 12 months if you make it in an acute care hospital. So you can predict. So this was published last year, Palliative Medicine. Merrin Gott, again, was one of the lead authors in this paper. It was a prospective study in acute hospitals in Auckland. What they looked at was, can we use the gold standards framework prognostic indicators in an acute hospital to predict, can we increase services, can we predict who's going to die? So they did a snapshot of all the patients on the wards. There was 22 of them, and had 501 patients, 99 of them who had one or more of the PIG triggers. They were oldish, mostly older than 83, but their average was 70. Just under half had cancer. There was 11% cardiac patients, but many of them had multiple comorbidities. In the identified group, that is the group that had one or more of the triggers, that was 20% of the patients. At 6 months, 57% of them had died. If we go another 6 months to 12 months, almost 2/3 of that identified group had died. So the triggers had been able to pick, these people have a significant chance of dying, compared to the non-identified group, and only 10% of that group died in the following 12 months. So if you're in the identified group, your odds of dying at 6 and 12 months is dramatically increased. So they summarise saying the GSF-PIG is highly specific and moderately sensitive. So potentially a tool when we're doing liaison work, maybe that will be helpful. This is now to look briefly at the AKPS. When David and Amy did this several years ago, they pitted it against the original Karnofsky score and the Thorne Karnofsky score, and it did very well. And these two, this graph down here is really just a highlight. If you've got an AKPS of 30 in the black, at about 3 months, 50% will have died. At about 6 months, we're getting down to about 60% will have died. So that falls in pretty well with the palliative performance score, which, in numbers wise, falls in with what Merrin Gott's paper looked at using the pig. This was just published in June of this year. We looked at it in Journal Club last week. It's using the ALS functional rating score to say, can we predict how fast you are going to change with your illness, using the initial ALS functional rating score at your initial visit. So that's a score out of 48 and involves swallowing, speech, writing, cutting up food, walking, ability, and respiratory function. So it's a score of 48. The lower the score, the worse you are. So what they did was took the numbers from the ALS score and then divided that by the number of months that you'd had the illness. And if your ratio, the rate of disease progression, was greater than 1.1, your odds of surviving were very low. So if you came in with this score of greater than 1.1 at the initial visit to the motor neuron disease clinic, the median length of survival was 8.4 months. Because sometimes, well not sometimes, all times, patients are asking, how long have I got? What's going to happen? And trying to predict is very difficult. And what I'm starting to think is, and I've asked David Schultz, should we be using this in our clinic? But should or could we be using this as we go and serially plot? And so if the curve's getting steeper. And there's a paper that we're going to look at, courtesy of Sue, this week in Journal Club, looking at the palliative performance score, not just at the first setting, but serially to see if we can plot more accurately and prognosticate a little bit more accurately. So in the motor neuron disease and chronic non-cancer illness, can we use this score to help identify, well, yes, you need to be ramped up in your care? And this was one of our favourites. He passed away a few years ago, but he was a typical patient in the motor neuron disease clinic. You can see the wasting, you can see the feeding tube, you can't really see his hands, but considerably wasted, no strength at all, and speech was pretty well gone by this point in time. But he had good quality of life. But the things when we put someone on ventilation are that the disease continues, it's relentless. Communication became so difficult with him in the end. He was locked in, and this does have significant impact on carers and so many unmet needs potentially, exhaustion for someone. And this is where we should be able to provide complementary care, social work support, art therapy, bereavement therapy. Why should a cancer patient get all of that and a non-cancer patient not get that? And I don't get it. Do we need to spend more time educating the heart failure nurses and the respiratory nurses to do some active planning, like Respecting Patient Choices program, to sit down and say what's important, instead of just watching their weight in the heart failure clinic or looking at their use of oxygen concentrator, sit down and do some planning, because they don't do that. The chronic illnesses are unpredictable. They get better, they deteriorate, they get better, they deteriorate, but they are spending an inordinate amount of time in hospital, and they have significant comorbidities. And as they deteriorate and they get weaker, the dependence on a caregiver or on the community or needing an aged care facility increases. I think there is very good evidence that by having a palliative approach to looking after these patients, that you can avoid futile investigations and treatment, and you can save a lot of money and a lot of hardship for patients. That there is evidence that we can actually improve the quality of life of patients, and we can help caregivers and the bereaved to move on more easily back into society following the death of their loved one. What tool do we use? I don't know. One that's simple, one that's intuitive, one that speaks a common language, and I wonder about the palliative performance score. I wonder about the GSF PIG as triggers for us to think about. I have to say I'm not sure whether PCOC's helping us or not. It's data collection, and I'm happy to be criticised and show where it is helping improve care, but it's not intuitive. You know, a score that goes from 1 to 3 to 4 instead of 1, 2, 3, 4 or percentage-wise doesn't make sense to me. So I'd like to see that it was helping improve care, and that's the one we do, but it's a conglomeration of 3 or 4 different scores. The AKPS is pretty simple and straightforward, and when you do the numbers from the AKPS, it's 60, look at a PPS and that's sort of similar. Maybe it just is the AKPS and just being alert, but I like the PIG because it gives you some specifics for a disease and it gives you some specifics for just general deterioration. There is a huge amount of work to be done about looking at how do we do it better, and prospective studies to be done in the future. And so I would welcome thoughts or questions or some solutions to the problem. So thank you very much for that. And it is your opportunity to get back at me because I always ask questions. So.
Thank you, Peter. Any questions?
I've got a question for you, Peter. Thank you. That's a really engaging presentation. I really enjoyed it, and I think it will be well received at the conference next month. Can I put you on the spot a little bit and just ask you a question about future care and the way that we're going with the proportion of patients who have cancer and those who have non-malignant conditions? And where do you see that balance settling in the future?
Well, it depends who the gatekeepers are. The balance may stay static if the gatekeepers don't change. So that depends on the gatekeepers and whether we say we're going to look after them, and we'll incur a little bit of hardship, but as we then start to develop and we can say to the government, we're at flat strap, we're now missing things, our care of patients is deteriorating because we're overwhelmed with work. So if we keep it status quo, nothing will change. If we use a tool or something to say, yes, we'll bring it on, it might change. SAPS is a little bit different because when I look at the numbers, and unfortunately we've lost Louise, who did keep really good breakdowns of stats. Patrick's trying to fiddle around with them, but he needs higher level access to delve into them. But our numbers, and Kate might correct me, our numbers of referrals are roughly the same, but and it was about an 75-80% cancer, 25% non-cancer. But the motor neuron disease skews our patient for non-cancer at the moment because we've got 90 on our books. So I think we've got about 400 active patients.
I just crunched the numbers this morning actually, and we're sitting more at 70-30.
70-30, yeah.
And the highest non-malignant group is the cardiovascular.
Mm-hmm.
So they, motor neuron disease is sitting down now about third out of the non-malignant group.
Right, so it's not...
And we've got about 500 active.
Yeah, so 500 active patients at the moment. So I think it will shift little bit by little bit. And whether we can, because they do have the same symptom needs. They have pain, they have breathlessness, they have fatigue, overwhelming fatigue, they have depression, and their caregivers come with all of their illnesses as well. So I think it will shift little bit by little bit, and that's why in Melbourne I'm really going to be interested because it'll be more workshop type format to see what others are doing. In Melbourne to date, it's been very difficult for palliative care to pick up motor neuron disease. They just didn't do it. So the MD Association went and got separate government funding to say to a palliative care service, here's Mr. Smith and here's a pot of money to look after him. So they're a big organisation, but prior to that, MD didn't get a look in Victoria, really, apart through Bethlehem and ventilation and things like that. So I think it'll change little bit by little bit if we want it to, and that'll be gatekeeping.
Peter, do you see a role for sort of FIFA, fly in, fly out, that people, because, as you said, many of these patients would be, long, might be 2 or 3 years or an extended time, so that I guess the scent is have to be very carefully done, but they come onto the books, there's some work, and they go out and come in, or workers go into them for post some sort of crisis, but then move out again.
It could be all of the above, and it could be, as Joe was telling this morning, it could be a really good day hospice. And anecdotally, and Joe might want to talk to address that, but the day hospice in the United Kingdom, with all of these chronic diseases coming in weekly, the number of admissions to hospital dropped dramatically. So just on a dollar cost or a pound cost, it's a huge saving. In quality of life, I would hope that they were safe, they were cared for, they were supported, they had a weekly meeting, they weren't isolated, they were fed once a week, they were stimulating their brain. Their quality of life, I would hope, flowed on with that as well. And so it could be that they're seen once every 6 months, a bit like what I often do with some of my severe COPD patients. I see them every 6 months. Sometimes I even get a stethoscope out. I'm chatting and asking how they're managing, what's important, how they're getting on, planning for the future. And if I don't need to do anything, we catch up in 6 months, but they know that there's a pipeline there. And so it could be lots of different models, but not our community nurses visiting all the time. But it could be empowering or teaching the respiratory nurse to do that active planning as well, have the plan in there and be supported.
So I can see the role of group work, and I guess a day hospice could incorporate just the fact, the role of support around different disease-specific groups.
Unfortunately, as we transform, we may not have the facilities up the hill, but the space, but maybe we will. Maybe we should be pushing for it to say, we think we can do this. Emma?
I was just going to say, I think also having the scoring systems, if they are sort of rolled out more, would be very helpful from a GP perspective as well, because then it gives us a bit of a better idea of when to start in referring to your services and things as well, and managing the patients.
I probably didn't make it clear enough. The gold standards framework is aimed around general practice. And then when you identify, they go onto a register and sort of it's highlighted. So the gold standards framework is all about general practitioners caring for patients and keeping them there and identifying things have changed, and you've got a couple of triggers. Oops, yes, we've got to gear this up. So, Kate.
I was just going to ask, because I heard somewhere along the line that the surprise question, they're thinking about reviewing that, and instead of asking if you'd be surprised if the person had died or was to die in the next 12 months, would you be surprised if the person was still alive? And whether or not you think that would help refine the way we think in terms of the chronic disease, because maybe it would really call on us to look at the information we've got. Because I mean, we could all die tomorrow because we've all get hit by the bus out the front. So if you turn it around and say, would you be surprised if they're still alive? I'm just wondering your thoughts on that.
I guess some people might understand that question more easily. I'd be surprised if you're alive at the end of the year. It's more in your face type thing, isn't it? Rather than would you be surprised if this person died? Instead of saying, I'd be surprised if this person was alive in 6 months. But gee whiz, I might get that wrong as well. Just that by itself. Do you know where that was from?
Well, it was to do with the gold standard framework, but they were actually seriously looking at turning that question around and putting that focus on it, because I think it would actually then, if your answer was yes, I would be surprised, it actually then puts the responsibility back on you to maybe start some advanced care discussions and talking about goals and actually shifting your head out of procuring at all costs to actually, I seriously would be surprised if this person's still alive. Therefore, there's a responsibility that I have as a clinician with that information to start some preparatory work about what the future might hold.
Pete, I'll come back to Diggs. Have you heard that, Jamila?
No, I haven't.
Haven't heard that, so we might have to do some investigation. Sorry, Pete.
There's a tool called the SPIC, the Supportive Palliative Care Indicators tool, which is part of the gold standards framework.
SPIC, yeah.
Yeah, single page. and it had the same framework as your teeth one, and it used to have the surprise question, and they've taken it out.
Yeah, I've had the spec and I haven't scanned it in yet. I thought I actually had 60 slides.
Because the most recent version of it, it's not in there anymore.
So maybe I should look at spec more closely. And I said on the weekend I unsuccessfully sent the slides to Anya, but I said I've got to stop looking because it was just getting bigger and bigger and bigger, and that's why that picture of the montage of all the scales, because it's just starting to do my head in. Which one do we choose or pick?
I think in aged care certainly we're using the PPS and the gold standard stuff, not so much as does the person need specialist palliative care, but just the would you be surprised almost, just to start the process much earlier on. And it goes back to what you were talking about before, the conversations they had about advanced care planning and goals of care and all those things. The less crises further down and the less chance you need to refer to specialist palliative care. I mean, my role is perhaps 30-40% typically what we know is sort of our role as specialist palliative care, and the rest of it is helping facilitate those conversations and trying to build capacity amongst the other staff so that they can do it. So
Because I don't think we can do it all.
and it's not, I'd even argue it's not necessary, because with that conversation and with a bit of planning to start with, things could go smoothly enough that people actually die well.
Yeah. I guess I would make a difference though, and I could be biased, but I think the motor neurone disease group is different to COPD and CCF, because I think they have such other complex needs with such a, for most of them, a shorter duration of illness. So I think they deserve definitely, probably, what do you think, Pamela, all of them need specialist palliative care support. I could be a bit biased in that, but they're a different group again. And that's why I think REPAP has just been so wonderful, allowing us to do this over the last 15 years and develop it. But yeah, not every patient who is frail or got COPD needs specialist palliative care. They need the discussions and the planning, because when they don't want to be kept alive artificially, most people. No one's had that discussion with them. And so it's that planning I think is important.
So just leading on from that point about what do you think about prognostication and complexity of patients and the division between specialist and generalist palliative care?
The prognostification is difficult, isn't it? Trying to look at some of the physiological parameters, and in cancer patients we've taken white cells, lymphopenia, protein levels, etc. I look at LDH as well if that's in the cancer patient. In the non-cancer patient, it's a little bit harder in trying to physiologically predict. I've got a young man with a myotonic dystrophy who I ventilated and helped calm deep squalene with because he flipped into AF. He's only 36. I haven't budged his CO2, so he's sitting on CO2 of 80, and I've been ventilating him now, and he's back at home. I didn't budge his CO2, so you can't use that as a marker either. So prognostification is really difficult, and that's where I think it comes down to performance more than physiology, because some of these people live with the worst physiology. You think, how do you survive with GFR of 10, a glomerular filtration rate of 10, kidney function? How do you walk around with a CO2 of 80? And when I first met this 36-year-old, he was knocked off. He was absolutely knocked off. But we ventilated him for a couple of weeks in intensive care with non-invasive, and I've got him back home now, and he's sharp as a tack, but his PCO2 is still sitting at 80. So the physiological parameters are not as reliable in the chronic setting because they just get used to hypoxemia and hypercapnia. They get used to running on a GFR of 10. But it means they are fragile and it doesn't take much to tip them over. And you give an older person with impaired renal function some trimethoprim for a urinary tract infection, you'll tip them into renal failure. So trimethoprim and UTIs are not a good mix in a frail older person, and you'll tip them into renal failure just like that. So because it's nephrotoxic, so they get along, they bumble along, but one little pebble and they'll stumble. specialist and generalist palliative care, I guess I see us as the intensive care of palliative care and the complex symptoms and the pain, difficult symptom management, which is refractory to other measures. For instance, COPD, maybe in the future morphine for dyspnea or morphine for heart failure and dyspnea. That general palliative symptom control the generalist or general physician should be able to do. They still need the supports of allied health teams as well in there, but we may be left with the really refractory issues, dysfunctional families, significant psychology and psychiatry aspects on top of that, which will become really province of the complex symptoms, both physical and mental, and maybe even sedation for those people where we're struggling. And there's a man that we just brought down from Flinders who needs that high level input. He's not died from his cancer, but his general medical conditions are such that his existential distress is stuff that he's asking for his life to be ended all the time. And he needs that complex psychiatry as well. So we're going to be, like the triangle shows, the very tip of it, really. We have to be able to do that. And if we're swamped because we've got everything else, we won't be able to do this well. But equally, we have to see lots of people to be able to do this little bit well, I think. We've got to be able to see a whole range to do the tip really well.
So as the triage nurse for the service and probably one of the gatekeepers.
You gatekeeper.
I'm the GP receptionist. Have you got any advice for me? Because they are often the challenging ones for accessing the service, about what it is that we can value add to their situation. And I think I often hear the community nurses, when I've triaged them onto the service at that point to be reviewed, is what are we going to be able to add to the situation. And a lot of them get referred, particularly the COPDs, are around their shortness of breath as well. And that is the main thing that they're asking for, and that's what the patients are asking for, particularly because a lot of them have already got community services. They've got maximum community services involved, and it's really what we can add to those situations. And I think that's probably what Robin would confirm, isn't it?
Yeah. Where might we add? Well, all the respiratory patients need to come for the dyspnea studies.
Yeah.
We need to maintain our role as the biggest recruiter in the country. So, is that right on there? That's perfect. Good answer.
And that's where the do come thanks to.
Yeah. I sometimes do wonder, I think, what have I added here? But sometimes I think what we add is our time. That in the good old days when I had the privilege of doing respiratory outpatients at Flinders, 15, 16 patients in a morning, you couldn't see them, talk to them adequately. You could write some scripts for some bronchodilators, a few more steroids, but you couldn't talk to them. It's expensive to talk. It's time consuming, but sometimes time is what we ourselves that we offer. So we shouldn't be undervaluing what we're doing by being there and being present, I think. That's not answering the gatekeeping question. Very hard to assess over the phone. And so at least an initial assessment.
And that's what we often do, is we say to them that we'll do an initial assessment to see whether there is anything that we can add to the situation. Most of them have got respiratory nurses involved, so it's around...
But I'm arguing, and I could be shot down, but I don't think they're doing that aspect of it. They're counting nebulizers, they're seeing how many hours their concentrator's on for...
Some
I could be being
very
a bit harsh.
They are stepping back when they know we're involved.
Yeah.
They are stepping back.
So I could, and there are more of them than community nurses. So they should be pushed to step up a little bit more. And I think back to Sharon Brandt's paper a few years ago when she presented the lung cancer. The people that were fronting up to the emergency department had stage 3B and 4 lung cancer, and none of those respiratory physicians had had a conversation about the what ifs or planning. And many of those patients that had fronted up to the emerge didn't have a new progressive disease or a sudden PE or an infection or a pleural effusion. It was they were isolated, they were frightened, they were short of breath, they didn't know what was happening. And if there'd been planning, and many of them had bad airways disease as well, if there'd been planning, that might have prevented it. Maybe the day hospice for that group and regular outpatients may be effective. We again have to be careful we don't get into the setting of having 14 or 16 patients in a clinic setting, so we don't get to give them time.
Well, interestingly, not many of the chronic diseases probably end up in clinic. I mean, I don't know whether we do have them in the clinics, but probably not because a lot of them aren't well enough by the time that they come on our books.
Okay. So I think the initial assessment, and then maybe what it is, it's that respecting patient choices, for want of a better word, program, that there are plans in place, and that will improve the outcome for the bereaved. And that's an important, and I'm sure Nikki could measure that in monetary terms of returning people back to the community, getting them re-engaged with community and activities. That may be a vital part. And that one-off session, and if that's once a year, one-off session, that may be important to say, how are we going, how many times you've been in hospital, are there any gaps that you've identified? Might be the important thing.
It's something that's been pushed in my year of general practice trainees, is that we should be referring early in diagnosis of like COPD and heart failure to a palliative care service just so they touch base. So I don't know if you're going to get an influx in the next few years as we come out into the community, but that's sort of what's been pushed from when we've been going through, so they should be touching base early, so I don't know if that would...
And maybe the GP shared care model, which we're still not sure how that's going to work, because it's not as neat and clean as obstetrics shared care. I'm doing one of the education sessions in a couple of weeks on that, so I'm not sure how that's going to really work, but that may be that there'll be over the years, because you have to do it. That's the thing with guidelines or tools, you have to put them out there and educate and disseminate and re-educate, and have to keep doing it all the time. So you're continually re-educating everyone. But that may in turn reduce what we're needing to do.
We at the moment have a wellness group for cancer, and I could just imagine a wellness group for COPD, a wellness group for the people with heart failure. I guess they need transport and all that sort of stuff, but I guess that's all taken care of for the
Respiratory have that though already.
Yeah.
Oh, okay.
We need to push that a little bit more, but maybe in those meetings you tackle a hard subject about death and dying in the COPD meetings. In the Lung Foundation guidelines, they don't like talking about dying. National Heart Foundation didn't want to be involved with palliative care because they don't want to talk about dying, because the patients don't die, but of course they do. So the head organisations don't want to talk about it, but at a wellness group for COPD or heart failure, or the MMD group, which we're trying to get the support group up and running again, talking to the carers and planning could be an important aspect. Kate, did you?
I was just going to say that I feel there's possibly a role with our GP class early introductory clinic for some of these, if they're coming out early from general practice, to have that one assessment that would allow us to actually do the whole psychosocial component, flagging anything, because the reason that clinic is set up was not necessarily to take everyone on travel, but to provide that comprehensive assessment, start a dialogue with the GP, saying, look, actually there isn't anything for us to offer at this point in time, it's back over to you, but sing out, if things change, come on back in. So I think there's still an opportunity to use that there, and it's not just a cancer-focused clinic. And we're starting to see some end-stage renal patients through that clinic, and they're usually just a one-off. They come in, have the discussions, and there's possibly some opportunity there. And in terms of the GP potentially the